Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. Today, I'm going to share with you this very interesting case as well as an important tip that you should pay attention to while reporting your daily cases. So this is a case of lobular carcinoma metastatic to the duodenum. And this is a 70-year-old female patient, a known case of a breast lobular carcinoma. And this should be really an alarming diagnosis because lobular carcinoma, once you see this diagnosis, you have always to pay attention to whatever biopsy you have, stomach, duodenum, endometrium, skin. Always be careful with this diagnosis because it's very deceiving. She presented with abdominal pain and was found to have a nodular duodenum. Now, this is the duodenal biopsy, some villi here, some blunting of the villi here, and really kind of busy stroma, but not much in really in the way of something that would eye-catching from the low power magnification. But remember, with lobular carcinoma, you have always to go on high power. So anytime you see lobular carcinoma in your history in the diagnosis, please go on high power examination. And then on high power examination, really busy lamina propria, lots of inflammatory cells with eosinophils, not much eye-catching. Apart from this really monster, big nucleus sitting here, and this one here, and then mitosis. And this should be alarming enough for you in knowing that the patient is lobular carcinoma to try to exclude that this is not, or yes, it is a lobular carcinoma infiltrating or invading into the duodenum. And this is near the surface epithelium. Again, not much on low power magnification, and even on high power magnification unless you have the index of suspicion. And whenever you start to see cells, cytoplasm with vacuoles, immunostain, this one here, tendency at Indian filing, if you really know what you're looking for, you start to see these things, and then you have, of course, to order immunohistochemistry. If you look at this one here, this is as if that the cell is sitting within a lymphatic space. And then the GATA3 was positive in the focus on several foci, actually, one of which was the first focus that I've shared with you. And then we did ER, and the tumor cells were like weakly to moderately positive with ER. PR was negative, and HER2/neu was negative or low expressor 1+. So the final diagnosis was this case was metastatic carcinoma from the patient's known breast lobular carcinoma. So please remember, whenever you encounter a case of a breast carcinoma in the history of whatever biopsy, you have to make sure whether this is ductal or lobular. If the case is lobular, please make sure to go on high power magnification, looking for any atypical cells. Even a slight atypia in the cells would be really suggestive. If there is lymphovascular invasion, that would be even more helpful. And always apply GATA3 immunohistochemistry to those cases, because you will be surprised. Many often those cases can be missed because of the deceptive bland appearance and their intermingling with inflammatory cells, which would really mask their malignant nature. I hope you find this tip useful in your daily practice. Thank you.